The measurement of vital signs will be a very important responsibility for you, the caregiver. If you recall, vital signs refers to the measurement of blood pressure, temperature, pulse, respiration, and most recently, the addition of pain. Today's topic of discussion will focus on what blood pressure is and how to accurately take a blood pressure. Hi, I'm Kathy Gatrust, and I'm an instructor in community health. What is blood pressure? Well, it's the measurement of the force of blood against the walls of the blood vessels in our body called arteries. The systolic pressure is the pressure in the artery when the heart contracts. The diastolic pressure is the pressure in the arteries when the heart relaxes between contractions. The first sound that's heard is the systolic pressure. When the last sound is heard before it stops, that's what's called the diastolic pressure. Blood pressure is always recorded as a fraction. For example, 120, the systolic pressure would be the number on the top, followed by 80, as the example shows, would be the diastolic pressure, and that's the bottom number. Numbers are measured as millimeters of mercury, abbreviated as mmHg. So, for example, 120 over 80 would be 120 over 80 millimeters of mercury. The blood pressure range is defined by a range of values. Healthy children and adults have quite a wide range of what's considered to be normal blood pressure values. It's important to know the normal range of your patient. The American Heart Association considers a blood pressure of less than 140 over 90 as a normal reading for adults. A systolic pressure of 130 to 139, and remember that's the upper number of the blood pressure, or a diastolic, or the lower number, a pressure of 85 to 89, to be pressure measurements that need to be closely watched. A blood pressure of 140 over 90 or higher is considered to be elevated or high blood pressure. A blood pressure of 180 over 110 or higher is considered to be a medical emergency and needs to be reported immediately so that immediate attention can be obtained for the individual. The American Heart Association states that the optimal blood pressure to prevent the risk of heart problems is that the blood pressure should be less than 120 over 80 millimeters of mercury. However, there is a point that it could be too low as well and might be indicative of some health problems. Hypotension, which is low blood pressure, can be caused by a number of factors: bleeding, malnutrition, medication, dehydration or lack of fluid intake or too much output can be sources of cause for hypo or low blood pressure. Hypertension, the opposite, high blood pressure, for example, 162 over 94, can have a number of causes as well. The main causes for hypertension are obesity, a family history of high blood pressure, smoking, anxiety, and pain. It's important that you report deviations to the nurse, those that are greater than 140 over 90 or less than 100 over 60. In addition, it's important for you to report any rise or fall in either or both the systolic or diastolic pressure of plus or minus 20 to 30 millimeters of mercury in consecutive readings. For example, let's say at 8 o'clock you got a blood pressure reading of 132/80. And shortly thereafter, your patient said she was feeling a little bit dizzy, getting a little lightheaded, was nauseated, and was getting a little bit unstable, and so you decided that it would be a good idea to get the blood pressure, or were directed to by the nurse. And at that time, the blood pressure was 92/72. You can see that the change from 132, the upper number, the systolic number, to 92 would certainly be greater than 20 or 30 points, and definitely needs to be reported, any change that's significant. There are a number of pieces of equipment that are necessary for blood pressure determination. The first is the stethoscope. This is a typical looking stethoscope. It's responsible for magnifying the sound that's heard when checking the blood pressure. It consists of the bell. The bell portion of a stethoscope is the smaller circle on the bottom, and the diaphragm is the larger side. It amplifies the sound. Originally, we always used this diaphragm side of the stethoscope to do blood pressure measurements. But more recently, it has been felt that the bell side really provided better low sounds that you might be hearing in the brachial artery. So it's best if you check with your instructor or with your facility to see what their current thinking is on the better side of the instrument to use. The next portion of the stethoscope is the tubings. There are two tubes, and the sound is carried from the diaphragm and the bell up through the tubes and into the earpieces at the top. The earpieces are responsible for directing the sound into the listener's ears. To hear the sound most clearly, the earpieces should be directed forward, as it is. I don't know if you can see that very well, but directed forward and down into the ear. So check the earpieces before you put them in. The other important thing to remember is you must always clean with an antiseptic wipe. The earpieces, I'll start with the diaphragm and the bell first. They're probably less dirty. Clean those areas off, and then clean the earpieces off using another part of the antiseptic wipe before and after using them on your patient. Besides the stethoscope, we have another apparatus. This is called the sphygmomanometer. Awfully long word, sometimes shortened up by being called a manometer. And a manometer consists of a cuff, and this is the cuff portion of the sphygmomanometer, just this portion. And inside this cuff is a rubber tube, a rubber cuff that air goes in. It's much like a balloon, and it inflates around the individual's arm. These cuffs come in different sizes, and it's important to use the correct size because you will get an inaccurate reading if the cuff is too narrow or is too wide for the individual's arm. I have a couple of other cuffs here. This one you can see is much smaller. This is a pediatric size cuff, and would be used for a small child. This one that I've shown you is considered an adult-sized cuff. The other one is a very large cuff. This particular cuff can be placed around a very large individual, or sometimes if their arms, for whatever reason, cannot be used for blood pressure determination, this large cuff can be put around their thigh. That's quite an unusual situation, and if that were the case, you'll be directed by the nurse as to what to do about that. But the important part I want you to know is that you want to use the correct size cuff for the individual. The width of the cuff should cover 2/3 of the individual's upper arm, so that's a good way for you to know whether or not you've got the correct size or not. There are 2 tubes on the cuff. One of the tubes is connected to the pressure control bulb and the bladder inside, and that's this particular one. This is the pressure control valve. And the other tube is connected to this pressure gauge that you see. The bulb and the valve at the very bottom of this sphygmomanometer is used to pump air into the bladder of the cuff and control the release of air from the bladder. And I'm not talking urinary bladder, we're talking about the balloon or bladder that's within the cuff of the blood pressure cuff. The bulb can be held in either hand. It's usually most comfortable in your dominant hand. I happen to be right-handed, and so it works best for me to place it in my right hand. And the valve can be turned clockwise. If it's turned clockwise, then you are closing the valve. And when the valve is closed, then you can pump air into the balloon-shaped bladder of the sphygmomanometer cuff. By turning the valve counterclockwise, you release the air and the cuff will deflate. The pressure gauge is the last piece that's a part of the sphygmomanometer. This one is called an aneroid type. It has a circular dial. It can be handheld or held onto the cuff itself. Sometimes you will see the aneroid type mounted on a wall, and you would be using the pressure gauge from the wall. There's another type that you'll see there that's a mercury type of pressure gauge. It is a rectangular column. It's not used nearly as much as it used to be because of the possibility of this breaking and causing a mercury spill. And you may have remembered from previous discussions, mercury is a very toxic metal and can cause lots of problems not only to our environment but to individuals as well. There are other styles of gauges as well, but suffice it to say they all basically work the same way. They just may be in a little bit different shape. Each line on the gauge measures 2 millimeters of mercury. For placement of the cuff, the first thing you need to do is to locate the brachial artery at the elbow and note the pulse. And then place the cuff snugly and smoothly around the arm, about 1 to 1.5 inches above the elbow, with the arrows on the cuff pointing toward the brachial artery. If the cuff slides down the arm, it's been placed on too loosely and will give an inaccurate reading, so it needs to be put on again a little bit more snugly. The way to read the gauge is marked with a series of lines. The large lines are at increments of 10 millimeters of mercury pressure. There might be a number next to that longer line, or there just might be the line itself. The shorter lines represent 2 millimeters between each one, so it's 2 millimeter intervals. Behind me I have a relatively new type of blood pressure apparatus. This is called an electronic blood pressure apparatus. It has a digital readout. It's used now in more and more facilities. It's considered to be very accurate and takes some of the guesswork out of blood pressure determination. It does not require the use of a stethoscope. It does have a cuff that's placed around the individual's arm, and it registers the reading on the digital display. And if you have that type of electronic blood pressure machine in your facility, check with the nurse who can rather simply explain to you how it works. Some points to remember when obtaining blood pressure measurement. Either arm can be used, according to the American Heart Association, for blood pressure determination. However, if both arms are perfectly capable of being used, they recommend that the right arm be used. Be sure to turn off any radio, television, or other source of distraction when taking blood pressure so that you can hear very clearly the blood pressure reading. The patient should be warm and comfortably lying or seated in a chair. Refrain from taking a blood pressure for 30 minutes after the patient has had a cigarette or other tobacco product. If the individual is seated in the chair, their legs should be flat on the floor and not crossed. If they are in bed, their legs should be straight and not crossed. Never measure blood pressure on a person's arm that has a cast, fracture, burn, or any other kind of injury. Also, it's important never to measure blood pressure on an arm where there might be an intravenous needle in it. Never measure a blood pressure on an arm that has had a recent blood test drawn. Also, if a person has had a breast removed, do not take the blood pressure on the side where that breast has been removed. And the last would be if a person has been paralyzed on one side due to a stroke or other neurological problem, do not take a blood pressure on that arm as well. The arm should be resting at heart level with the palm facing up. The arm should never be elevated above or below the heart level. The cuff needs to be applied directly to the skin. If possible, to roll the sleeve up, that's perfectly fine. But if it becomes too tight by having it moved up and is constricting the upper arm, or if you simply cannot have the cuff applied directly to the skin in that instance, then you would ask the individual or assist the individual to take that outer garment off. The cuff must be completely empty and flat before placing it on the arm. If you're unsure of your reading, you may wait 1 minute or longer and then retake the blood pressure on that same arm, or you could try taking the blood pressure on the opposite arm. If after 2 attempts you just are not certain about your blood pressure reading, then ask the nurse for assistance. Don't ever hesitate to ask the nurse to check your blood pressure reading. Checking and taking a blood pressure is a skill that takes time to perfect, and it's very difficult to become proficient after only learning the skill. Blood pressure measurements are recorded in even numbers. So, for example, if you felt like you got a blood pressure measurement that was a systolic pressure of 119, you would round that up to 120. Now I'd like you to watch a demonstration of taking a blood pressure. You will not be able to hear any of the sounds of the blood pressure, but I'd like you to focus instead on the blood pressure technique. Measuring blood pressure. Wash your hands. Gather needed equipment. Remove the sleeve if needed. Place the patient in a comfortable position with arms supported on the bed or table, palm up and at heart level. Clean the earpieces and the diaphragm of the stethoscope with an antiseptic swab. Point the earpieces forward prior to putting them in the ears. Test the diaphragm and bell to be certain that the tapping sound is heard. Check the gauge that it is at 0 before starting. Palpate the brachial artery. Center the bladder of the cuff over the brachial artery and 1 to 1.5 inches above the elbow. Estimate the systolic pressure by placing the bulb in the dominant hand for pumping it up, feeling the radial pulse with the other hand, inflating the cuff to 90 millimeters of mercury and increasing at 10 millimeter increments until the pulse is no longer felt. This is the estimated systolic pressure. Deflate the cuff rapidly and wait 30 seconds. Keep a mental note of the systolic pressure. Center the stethoscope over the brachial artery. Inflate the cuff quickly to the estimated systolic pressure that you obtained earlier. Release the valve and watch the needle or mercury descend at 2 to 4 millimeters per second. Listen for at least the first 2 consecutive beats. Note the number, but do not stop the descent. Continue deflating the cuff until the last sound is heard. Listen for another 20 millimeters, then release the remainder of the air in the cuff quickly. If you're uncertain of your reading, repeat the inflation of the cuff after 1 to 2 minutes. Record the reading on paper. Report the deviations to the nurse. Now that you've seen the demonstration of taking a blood pressure, this is going to be your chance to listen to some sounds on the following exercise, and I'd like you to write down in your student manual what you heard on each of these 6 examples of the systolic or the upper pressure number and the diastolic. And once you have listened to all of them, you can check your results with the answers that will be at the end of the tape. Remember that when you are listening for the systolic pressure followed by the diastolic, you want to be hearing at least 2 or more consecutive sounds before you determine that that in fact is the accurate reading. I'd like you then, if need be, if you get more than 4 millimeters of mercury difference from the answers at the end of this tape, I'd like you to replay those 6 sounds again and see if you can make an appropriate correction to them.
Record the systolic and diastolic measure for each sequence. At the end of the test, the answers will be provided for the benefit of those of you who view this tape without an instructor. Now, compare your recorded measures with the answers. If any single measure differs as much as plus or minus 4 millimeters of mercury, you should repeat the entire test section of this tape. You may wish to refer to the manual or other parts of this tape for clarification of the technique.